Larry King spoke to us recently, and he took off his jacket to say, "I just wanted you to believe I'm Larry King." Well, I'm not Larry King. Thank you, Bob and Marion, for inviting me to participate in CCAN's annual conference. It's a pleasure and an honor to join your distinguished panel, and I, too, am thinking of Monica as I give this presentation. It is customary to provide a disclosure of anything which might influence the content of one's presentation. This is my disclosure. Some years ago, Dr. Richard Warner asked me to see in consultation a patient with heart disease caused by a neuroendocrine tumor. The patient had a heart murmur, a congested liver, and edema of his legs. In all honesty, Richard knew the cardiac diagnosis, and he knew the therapy which would most likely arrest the devastating cardiac valvular disease, which was the result of the patient's carcinoid cancer. Although I had read about carcinoid heart disease, I had never before examined a patient with carcinoid heart disease. I had seen a patient with the carcinoid syndrome. He was my father's close friend. I observed the characteristic flush associated with his disease. However, that patient referred to me by Dr. Warner represented my introduction to heart disease caused by a neuroendocrine tumor. Often when one mentions the phrase carcinoid heart disease, the person hearing it immediately thinks of tumor in the heart, when in reality, 95% of patients with carcinoid heart disease do not have tumor directly involving the heart muscle. Rather, they suffer the effects of substances released by a neuroendocrine tumor called carcinoid cancer. These tumors have been loosely referred to as being functional and non-functional, depending upon whether or not they secrete substances which cause readily observable symptoms. Patients with a carcinoid syndrome, by definition, have functional tumors, and patients with carcinoid heart disease almost invariably have the carcinoid syndrome. Although there are more than one candidate substances released by carcinoid cancer, which might contribute to the problem which is referred to as carcinoid heart disease, at present, the single most damaging substance seems to be serotonin, a substance whose level can be measured in the blood and whose circulating concentration often correlates with the magnitude of the symptoms of the carcinoid syndrome, which include flushing, diarrhea, sometimes wheezing, and blood pressure fluctuations. The concentration of serotonin also correlates with the likelihood of a carcinoid cancer to produce the damage to the heart, which is referred to as carcinoid heart disease. The circumstances which set the stage for carcinoid heart disease are quite compelling. Carcinoid tumors frequently have metastasized or spread prior to their being diagnosed, and the liver is a frequent site of the metastases. The carcinoid tumors in the liver often secrete serotonin in high concentration, and since blood from the liver goes directly to the heart is exposed to highly concentrated serotonin. The inner lining of the heart contains serotonin receptors, which, when exposed to serotonin, stimulate cells called fibroblasts. These cells proliferate, producing scar tissue within the heart. This scarring can affect the function of the heart muscle as well as the function of the valves. And it is predominantly the involvement of the valves which signals the existence of carcinoid heart disease. It is interesting to note that the damage to the heart affects predominantly those structures closest to the liver, which we refer to as the right heart. Specifically, the structures most often affected are the two right heart valves, the tricuspid and pulmonic valves. The reason for the usual lack of significant involvement of the valves of the left heart, the mitral and aortic valves, lies in the curious fact that serotonin is inactivated or rendered harmless as it passes through the lungs on its route back to the left side of the heart. In fact, if there were involvement of the left heart valves by carcinoid heart disease, one would be compelled to look for the explanation of how a high concentration of serotonin might have reached the left heart. Instances of left heart involvement are usually explained on the basis of the existence of a hole in the heart, an atrial septal defect or patent foraminal valley, or carcinoid tumor in the chest or lungs, secreting serotonin in high concentration into the blood returning to the left heart, thereby affecting the mitral and aortic valves. Carcinoid heart disease can develop and progress gradually, or it can be rapidly progressive, depending predominantly upon the level of serotonin in the blood. The result of serotonin's damage to the right heart structures is termed right heart failure. Serotonin's predominant damage to the tricuspid and pulmonic valves results most frequently in a leaking or insufficiency of these valves. The scarring of the valve leaflets prevents them from sealing tightly when they close, and the scarring sometimes restricts their opening motion as well, a condition referred to as stenosis of the valve. Major consequences of these valve abnormalities include the development of lower extremity swelling or edema, and at a more advanced stage, abdominal fluid accumulation or ascites. These conditions of fluid accumulation are the direct result of the increased back pressure in the veins carrying blood from the legs, abdomen, and liver to the right side of the heart. Whereas blood normally flows from the legs, abdomen, and liver to and through the heart, forward flow being maintained by the valves of the heart, when these valves malfunction, either by leaking or by being narrowed or stenotic, blood tends to back up, resulting in a rise of pressure within the involved veins. If the pressure remains abnormally high, fluid leaks out of the blood vessels and into the tissues of the legs, forming edema, or into the abdomen, forming ascites. There are significant consequences of the fluid accumulation in the legs, liver, and abdomen. Swelling of the legs results in poor tissue perfusion or blood flow, compromising the health of the leg tissues and rendering the legs susceptible to trauma and infection. The accumulation of excess fluid within the abdomen is associated with swelling of the organs of the abdomen, including the bowel. Bowel edema results in diminished absorption of nutrients from the intestines. The resulting malabsorption syndrome, including the loss of muscle mass, is a malnutrition state sometimes referred to as cardiac cachexia. The increased back pressure associated with right heart carcinoid valve disease creates a condition in the liver referred to as a congested liver. It is this important condition which often dictates the order of sequencing of therapeutic approaches in a patient with the carcinoid syndrome with accompanying carcinoid heart disease. That is, in the setting of ascites with a congested liver, it is deemed most appropriate to fix the heart first, thereby normalizing the pressure within the liver and making it safer to proceed with tumor reductive surgery or procedures in the abdomen and liver. Surgery is most often directed at the valves, which are scarred and deformed due to the effects of excessive serotonin. Tricuspid and pulmonic valve replacements represent the most common cardiac surgical interventions among carcinoid patients. Prior to surgery, a decision has to be made concerning the type of prosthetic valves to be implanted. The major choice involves the selection of a mechanical valve made of metal or a biologic valve made of tissue from a pig or a cow. The biologic valve can free the patient from the need for daily use of Coumadin, the brand name for warfarin, an anticoagulant medication. The mechanical valve has the advantage of lasting longer, theoretically free of the ravages of serotonin. The disadvantages of these choices involve the mechanical valve's requirement for Coumadin to prevent prosthetic valve thrombosis or clotting, and the biologic valve's susceptibility to ongoing damage by serotonin, potentially resulting in the need for a reoperation due to the serotonin-induced destruction of the tissue valve. Usually, a discussion with the patient encompasses the desirability to avoid Coumadin anticoagulation if future surgical or other invasive inventions are deemed likely, provided it is anticipated that interventional and/or medical therapy is likely to reduce serotonin to acceptable levels. Where it is deemed unlikely serotonin will be controlled, serious consideration is given to the selection of mechanical valves in an attempt to diminish the likelihood of repeated cardiac valve replacements. In addition to valve surgery, open heart surgery is used to close any interatrial communication, such as an atrial septal defect or patent foramen ovale. This would eliminate a pathway for serotonin to directly enter and damage the left heart. Rarely, there is carcinoid tumor within the heart muscle. The approach to anti-tumor therapy in our hands, when tumor has invaded the heart, has been non-operative chemotherapy with careful monitoring of the tumor using repeated cardiac MRI studies. Other cardiopulmonary surgical procedures for infrequent complications of carcinoid heart disease have included the following. For the uncommon creation of a conduction system abnormality referred to as a heart block, cardiac pacemakers have been implanted to prevent bradycardias or slow heart rhythms from causing syncope or fainting. In the rare instance of excessive scarring around a lung resulting in pulmonary entrapment or the restriction of lung expansion causing extreme disability with shortness of breath and fatigue, the scarred pleura, the surrounding lining of the lung, is surgically removed, sometimes using minimally invasive techniques. In instances of heart failure resulting from damaged or weakened heart muscle, medical therapy is required and usually involves multiple medications. The predominant classes of drug therapy used for the treatment of heart failure include the following: diuretics, including Lasix or furosemide, hydrochlorothiazide, spironolactone, and others. These are used to remove excessive fluid from the body. Beta blockers, including propranolol, atenolol, metoprolol, carvedilol, and others. These are used to slow the heart rate, thereby enabling the heart to pump more efficiently. ACE inhibitors, angiotensin-converting enzyme inhibitors, including lisinopril, enalapril, fosinapril, ramipril, and others. These are used to dilate the peripheral arteries, thereby reducing the body's blood pressure and reducing the workload on the heart. And there are newer vasodilators called angiotensin receptor blockers, and direct renin inhibitors, which can be used in place of ACE inhibitors. And finally, digoxin, this age-old medication from the foxglove plant, strengthens the contractility of the heart muscle and helps control the rhythm. The above remarks have addressed some issues concerning how cancer affects your heart, with particular focus upon carcinoid heart disease. There are other effects of cancer and/or cancer therapy upon the heart. Some anti-tumor drugs can adversely affect the heart, causing the heart to go into heart failure. Perhaps most notable is the drug adriamycin or doxorubicin. The detrimental effect upon the heart is dose-related. If caught early, the resultant heart failure is reversible. Therefore, it is prudent to perform an echocardiogram prior to each dose of the drug. A 10% decrease in the pumping action of the heart, represented as the ejection fraction, signals the need to discontinue the drug. In instances wherein the decrease in ejection fraction was not appreciated, the ensuing clinical manifestations of heart failure have responded to traditional heart failure therapy. Newer drugs, including one or more of the experimental monoclonal antibodies, have proven to have cardiac toxicity, prompting the cardiologist to keep one's eye ever on the horizon for drug-induced toxicity. Nutritional risk has long been recognized as a confounding factor in the cancer patient. Decreased appetite should signal that risk and lead to a set of therapeutic responses designed to stimulate the appetite and maintain the patient's caloric intake. A significant drop in weight, sometimes referred to as cachexia, can decrease muscle mass throughout the body, including the heart muscle. The resultant weakening of the heart increases the risk of heart failure. Malnutrition can occur due to ascites, and ascites can be due to tumor or it can be due to heart failure. The malnutrition results from bowel edema or swelling of the intestines. So now we've turned the corner. We have switched from speaking of how cancer can affect one's heart to the reverse, how the heart can affect one's cancer. The heart failure referred to above can be due to any of a number of causes. Hypertension is perhaps highest on the list. Its frequency among the population is high, and the tendency toward heart failure is so great that in the more recent classification of heart failure severity, hypertension has been termed Class 1 heart failure. That means if one has hypertension, he is deemed a patient with early heart failure. Valvular heart disease is another potential cause of heart failure, and it too is quite common. And valve problems tend to be worsened by concomitant hypertension. So persons with both hypertension and heart lesions are at even greater risk of heart failure. Coronary heart disease is another potential cause of heart failure, most often due to scarring of the heart due to myocardial infarction or heart attack. It is somewhat unusual for coronary artery disease to cause heart failure without myocardial infarction. However, it does occur when a critical narrowing of a major coronary artery threatens a large amount of myocardium or heart muscle, rendering it ischemic or lacking adequate blood flow and oxygen, thereby producing heart failure. Other causes of heart failure include congenital causes, including those which cause abnormal thickening of the heart muscle, with resultant stiffening of the walls of the heart. Infiltrative diseases of the heart, which impair heart muscle contractility, and endocardial diseases in which the inner lining of the heart is either scarred or infiltrated with abnormal substances, resulting in a stiffening of the heart with loss of elasticity as well as a loss of contractility, which we quantitate using the term ejection fraction. Whatever the cause of heart failure, the sequence of events commonly unfold as follows. For causes of heart failure residing within the left heart, the resulting heart failure causes a backup of pressure into the lungs. This manifests itself as shortness of breath, chest tightness, and sometimes palpitations. For causes of heart failure residing within the right heart, the resultant heart failure causes a backup of pressure into the liver, abdomen, and lower extremities, and manifests itself most commonly as exertional fatigue, right-sided upper abdominal pain due to congestion of the liver, ascites, or fluid within the abdomen, or edema, swelling of the lower extremities. In the context of implementing strategies to arrest and eradicate cancer, it is critically important to prevent or treat heart failure, lest its symptoms and hemodynamic effects interfere with the optimal functioning of the body. Prevention of left heart failure entails controlling the blood pressure. In general, one should attempt to maintain a blood pressure within the low normal range, approximately 100 to 125 millimeters systolic, and a diastolic of 80 millimeters or less. Although antihypertensive blood pressure medication includes both diuretic and vasodilating medications, the body experiences better blood flow and tissue perfusion with the vasodilators. Indeed, the blood vessels of the body dilate with the use of these drugs, thereby reducing the workload of the heart and increasing the heart's cardiac output. On the contrary, although diuretic medications reduce blood pressure by reducing the amount of circulating blood volume, a simultaneous constriction of the body's blood vessels occurs, resulting in a decrease of one's cardiac output. As a result of these differential effects upon the body's blood vessels, it is worthwhile to attempt to control the blood pressure with vasodilators. Although this is the ideal scenario, sometimes the blood pressure remains elevated, necessitating a compromise in the form of combined therapy with both a vasodilator and a diuretic. Prevention of right heart failure entails controlling left heart failure. Yes, you heard me correctly. Since left heart failure is the most common cause of right heart failure, the treatment of left heart failure is often the first step in treating right heart failure, usually starting with the treatment of an elevated blood pressure. Other common causes of left heart failure involve the diseases of the two left heart valves, the mitral and aortic valves, and therefore, if severe dysfunction of one or both of these valves were at the root of the patient's heart failure, consideration would be given to the repair or replacement of these valves. Treating reversible pulmonary disease, perhaps the most easily missed but most readily treatable chronic pulmonary disease, is that of chronic pulmonary embolism. It occurs most often when blood clots, often originated in the deep veins of the legs, travel repeatedly from the legs through the right heart and lodge in the arteries of the lungs. The resultant obstruction of blood flow can ultimately lead to pulmonary hypertension. Short of surgery, anticoagulation is essential to successful alleviation of this disorder. Other forms of pulmonary hypertension are characterized by vasoconstriction or narrowing of the pulmonary arteries. This form of pulmonary hypertension can be perplexing. Sometimes this group of diseases responds to various classes of vasodilators, and sometimes the problem is resistant to therapy, allowing no improvement in the resultant right heart failure. Treating right heart valve disease, as mentioned earlier, significant disease of the tricuspid and/or pulmonic valves causes right heart failure and is amenable to replacement of these valves. Treating right ventricular scarring. Right ventricular scarring resulting in a decrease in the contractility or ejection fraction of the right ventricle poses a significant problem. In fact, if present, it may represent a contraindication to the attempt to replace the tricuspid and/or pulmonic valves. At the very least, it represents a significant negative factor in predicting the outcome of valve surgery. Unfortunately, until now, there is no surefire therapy to reverse the scarring of the heart's inner lining once carcinoid heart disease has progressed to the point of right ventricular failure due to the loss of contractility of the right ventricle. The knowledge of how cancer affects one's heart and how one's heart can affect one's cancer empowers us to do something about each of these issues to enhance the likelihood of success of strategies to resolve the problems created by cancer. Doctors Woltering and Warner and others around the world have concluded that a team approach to cancer therapy is most appropriate. And this has been underlined by our speakers that preceded me. They realized there was so much to be gained by the collaboration of multiple specialists in the effort to focus on the patient. It has taken courage on the part of patients and their families, and courage on the part of doctors to choose an option such as open heart surgery to enable a successful battle against cancer. And there are rewards. Today, tumor reductive surgery is routinely performed on patients who present with well-advanced stage 4 cancer, not limited to neuroendocrine tumors, but many others as well. This has often been made possible by the repair of the heart. And today, the problems created by ascites and edema can predictably be controlled with careful medical management. Actually, the medical management of fluid accumulation is to a large extent the same strategy as that of controlling heart failure and hypertension. Only the care is a bit more meticulous. The approach is rather simple, and it requires a close collaboration between the patient and the cardiologist. It entails the use of one or more diuretics, often with a beta blocker, and an ACE inhibitor, or an angiotensin receptor blocker. The patient's role is to take the medication, check one's weight each morning, and check one's blood pressure sitting and standing each morning, and record the data. The data are reviewed with the cardiologist approximately twice per week, or more often, if necessary. Adjustments are made over the phone to ensure a gradual removal of edema and ascites with the excessive depletion of intravascular fluid, that is, without removing too much blood volume too quickly, thereby avoiding syncope or fainting. Such a patient is re-examined by the cardiologist approximately every 3 to 4 weeks, at which time the physical exam is augmented by a non-invasive determination of peripheral vascular resistance and cardiac output with a test similar to an EKG called thoracic bioimpedance. Chest x-rays might be taken, and blood tests are done to monitor the kidney and electrolyte changes expected with the use of diuretic therapy. An expected reward of close monitoring by the cardiologist is the risk reduction expected of the management of cardiovascular risk factors, including hypertension, mentioned above, hemoglobin A1C, the diabetic marker, lipid markers, especially HDL cholesterol, LDL, and triglycerides, homocysteine, vitamins, especially B12, folic acid, and vitamin D, physical activity, lifestyle, diet, and emotional state, especially depression. An added reward of the meticulous attention to these cardiovascular risk factors is the added safety of repairing one's body or fighting one's cancer with enhanced control of one's cardiovascular status, providing a greater margin of safety. It is reasonable and it is prudent to ensure the optimal performance of one's heart when navigating the hills and valleys of the battle against cancer. Many of you know Dr. Warner in a medical context as an extraordinarily experienced physician. Some of you know that he is also an extraordinarily experienced pilot. On one occasion, Dick asked me to accompany him on a flight to New Hampshire, and he advised me that he would instruct me on the use of the plane's flight instruments. And you all know that the telling of a story is often much better if one is able to embellish the truth. Well, this is where the embellishment starts. So I would serve as his navigator. As I was about to step into the cockpit, please note that in the slide, Dick reached into his pocket and pulled out his pistol and put the gun on the dash. Of course, I asked what that was for, and Dick responded, "That's in case we get lost." I proceeded to seat myself in the co-pilot seat, reached into my pocket, and placed my pistol on the dash, whereupon Dick asked, "What's that for?" I responded, "I think I'll know if we're lost before you do." This is a shot of Dick on the Cafe Lafayette dinner train in North Woodstock, New Hampshire. On the return trip from New Hampshire, I shot several photos of a spectacular sunset from his plane. However, I did not realize the flash function was not turned off, and Dick was nearly blinded by the flash in the cockpit when I took this photo. It was very fortunate that I was wearing my parachute when Dick made sure I didn't do that again. Thank you for the opportunity to spend this day with you.